Welcome to the overview of the prescription opioid and heroin crisis webinar provided through a collaboration between the Pennsylvania Medical Home Initiative, a program of the Pennsylvania chapter of the American Academy of Pediatrics, and funded by the Pennsylvania Department of Health. This webinar aims to obtain a better understanding of the opioid epidemic in Pennsylvania. It will describe the concept of opioid stewardship and the functions of PDMP. Also discussed will be the process of rescue with naloxone, warm handoff, and treatment. My name is Dr. Renee Turchi, and I'm a pediatrician at St. Christopher's Hospital for Children and medical director of the Pennsylvania Medical Home Initiative. This webinar is recorded. The recording will be available by both the Pennsylvania Medical Home Initiative and will be posted on the University of Pittsburgh Internet-based Studies in Education and Research ISER website. For CME purposes, please be advised that Dr. Levine nor myself have any disclosures. Please note that the information presented in this webinar is educational in nature and does not necessarily represent the views or policies of the Pennsylvania chapter of American Academy of Pediatrics or the funders. Now, please allow me to introduce our presenter, Dr. Rachel Levine. Dr. Levine is currently the Secretary of Health and Physician General for the Commonwealth of Pennsylvania and Professor of Pediatrics and Psychiatry at the Pennsylvania State College of Medicine. As Physician General, Dr. Levine has made significant strides combating the opioid epidemic and advocating on behalf of the LGBTQ population. She spearheaded the efforts to establish opioid prescribing guidelines and establish opioid prescribing education for medical students. She has also led an LGBTQ work group for the governor's office, which has worked to create programs and processes that are fair and inclusive in healthcare, insurance, and many other areas. Recently, Dr. Levine was recognized as one of NBC's Pride 30, a national list of 30 people who are both members of and making a difference in the lives of the LGBTQ community. Her previous posts include Vice Chair for Clinical Affairs for the Department of Pediatrics and Chief of the Division of Adolescent Medicine and Eating Disorders at the Pennsylvania State Children's Hospital Milton S. Hershey Medical Center. Dr. Levine graduated from Harvard College and the Tulane University School of Medicine. She completed her training in pediatrics at the Mount Sinai Medical Center in New York City and then did a fellowship in adolescent medicine at Mount Sinai. She then practiced pediatrics and adolescent medicine in New York City and was on the faculty at the Mount Sinai School of Medicine. She came to Central PA in 1993 as the Director of Ambulatory Pediatrics and Adolescent Medicine at the Polyclinic Medical Center. She joined staff at the Penn State Hershey Medical Center in 1996 as the Director of Pediatric Ambulatory Services and Adolescent Medicine. Her accomplishments at the Penn State Hershey Medical Center include the initiation of a division of adolescent medicine for the care of complex teens with medical and psychological problems. In addition, she started the Penn State Hershey Eating Disorders Program, which offers multidisciplinary treatment for children, adolescents, and adults with eating disorders such as anorexia nervosa and bulimia nervosa. She was the liaison for the LGBT community for the Office of Diversity at the Penn State College of Medicine. In that role, she had established an LGBT faculty and staff affinity group and was the facilitator for the LGBT student group. Dr. Levine teaches at the Penn State College of Medicine on topics in adolescent medicine, eating disorders, and transgender medicine. In addition, she has lectured nationally and internationally and has published articles and chapters on these topics. We are delighted to have Dr. Levine present on this timely and important topic for primary care clinicians. Dr. Levine, please begin your presentation. Thank you.
Good afternoon. This is Dr. Rachel Levine, and I'm the Secretary of Health for Pennsylvania and a professor of pediatrics and psychiatry at the Penn State College of Medicine. And most importantly, I'm a pediatrician. So I trained in pediatrics and then adolescent medicine at Mount Sinai, and I have been working as a pediatrician and adolescent medicine specialist at Penn State Hershey for many years before I became Secretary of Health. So what we want to talk about is really the biggest public health crisis that we have in our time, which is the prescription opioid and heroin crisis. So the learning objectives are to describe the state of the opioid epidemic in Pennsylvania, talk about this concept of opioid stewardship, including our prescribing guidelines, discuss the prescription drug monitoring program, and talk about naloxone and rescue, the warm handoff to treatment, and expansion of treatment, and then talk about our new opioid disaster declaration and how we're operating now in a command center structure. So, as I mentioned, this is an epidemic. Usually when we think of epidemics, we're thinking in terms of infectious diseases, but it follows that model. In 2016, there were over 4,600 drug-related overdose deaths in Pennsylvania. And in 2017, that is over 5,000, with significant increases year by year. So right now in Pennsylvania, 13 to 14 individuals each day die of drug overdoses, and by far more Pennsylvanians and Americans die of drug overdoses than of motor vehicle accidents. If you look at this slide from the CDC from 2000 to 2015, you can see in the green any opioid overdose. You can see in the kind of dark blue purple that initially this was commonly prescribed opioid overdoses, which has plateaued, and then almost exponential increases, which have continued in 2016 and 2017 from heroin, and then synthetic opioids such as synthetic fentanyl compounds. You can see in this slide, which is from 2016, states that have statistically higher overdose deaths than the general United States, and you can see that line down the Appalachian Mountains from Maine, New Hampshire, Massachusetts, Connecticut, Rhode Island, Pennsylvania, Maryland, West Virginia, Ohio, Kentucky, etc. There have been states in the West, as you can see, that have been as severely affected by overdoses, but the Northeast and Mid-Atlantic has been the epicenter of this crisis. In Pennsylvania, from 2016, you can see significantly high rates throughout the state. The highest is in sort of the darker brown orange. And it really covers many aspects of our state. This is an urban phenomenon, as well as suburban, as well as rural. The death rate in many rural counties, including Fulton County, Cambria County, etc., are as high, if not higher, than they are in Philadelphia County. So this has no urban predominance as maybe previous drug crises have had. In terms of age, we see higher rates in individuals 20s, 30s, 40s, and 50s, but we do see adolescents with significant rates of opioid overdoses, as well as seniors. There are more males than females, but an increasing rate of change for females, and so it really affects every demographic group that you would look at. Overdose deaths among adolescents in the United States, you can see has been trailing up from about 2012, 2013, 2015, and the death rate from 14 to 15 increased 19%, and those trends have continued into 16 and 17. So this is a significant issue for adolescents. More males than females, but significant increases for young women as well. Overdose deaths involving opioids has gone up significantly since 2000. There was somewhat of a plateau for a number of years, and now since about 13, 14, we're seeing continued increases. And that has continued in 16 and 17. So where other overdose rates had stayed at a pretty plateau level, we're seeing significant rates of not only overdoses, but opioid overdoses in adolescents. And the rates of drug overdose deaths in 2015 due to opioids among adolescents was highest for heroin. I think that might surprise some of us. And you can see at the bottom that almost exponential increase in the darkest, almost black, of synthetic opioids, and that is synthetic fentanyl, which has become one of the biggest problems that we have that we are seeing. This is all adolescent data from the CDC. So the rates of 15 to 24-year-olds of accidental poisoning increased sevenfold from 1979 to 2014. So this is an issue for all physicians, including pediatricians and adolescent medicine physicians. As you know, addiction is a chronic relapsing brain disorder with circuit changes, particularly in dopamine pathways, involving reward circuits, stress response circuits, and decision-making circuits. The brain changes can persist after the substance abuse ends, and the adolescent brain, patients we take care of, is at increased risk because it is still developing really into the early 20s. I would highlight the Surgeon General's report released in November 2016 on facing addiction in America. This was from Dr. Vivek Murthy, the previous Surgeon General. It's an excellent document. Now, what you have to remember are these two statistics, and they're somewhat different. And so let's go through those. 80% of individuals that are using heroin actually started with prescription opioids that they obtained legally from their physician or illegally from the black market, but they started with actually prescription opioids. Now, not everyone who used or misused opioids ends up using heroin, about 4 to 7%. But if you're using heroin now, you actually almost always started with prescription opioids. And this article by Compton in New England Journal of Medicine 2016 highlights this relationship between non-medical prescription opioid use and heroin use. So let's talk about how we got there. For those physicians and pediatricians that are of my generation, I'm sure you remember in the 90s and in the 2000s, the increased emphasis on the identification of pain. That there was, through efforts of the Joint Commission, Center for Medicare and Medicaid Services, pain societies, etc., that the medical community had to do a much more robust job assessing and treating pain. And thus we developed the pain assessment tools, the smiley faces, etc. Pain became the quote-unquote fifth vital sign. And so that not only was that acute pain, but also chronic pain, and not only severe pain, but actually mild to moderate acute and chronic pain. And unfortunately, the expectation became that not only were medical providers going to assess and treat pain, but we were going to essentially eradicate pain. And at the same time was the development of extremely powerful, long-acting opioid pain medications that were marketed that they would not be addictive to patients with pain. And unfortunately, we have shown that that is completely false, is that patients with acute and chronic pain are very susceptible to becoming dependent and potentially addicted to opioid pain medications. But since 1999, the amount of prescription opioids sold in the United States went up 400%. Since 2012, healthcare providers have written enough painkillers for every American adult to have a bottle of pills. And again, 80% of people who use heroin reported the non-medical use of prescription opioids. And so we really had a society that was becoming very dependent and potentially addicted to opioids. And so the third piece of the puzzle has been the influx of extremely cheap, powerful, and plentiful heroin into the United States over the last probably eight or more years. And so the heroin today is much higher in purity. It is available everywhere, and it's extremely cheap. And that's the third piece in the puzzle that has led to the explosion of addiction and overdoses in the United States. And it's even worse than that because we have dangers of synthetic fentanyl compounds. Now, this is not diverted fentanyl, the medication fentanyl. This is synthetic fentanyl produced primarily in Asia and then sold either through the cartels and used to cut heroin because of how cheap it is to produce, or sent in the United States through orders on the quote-unquote dark web. So fentanyl has been playing an increasing role in overdose deaths since 2013. The majority of opioid overdose deaths now indicate the presence of fentanyl. It can be used to cut heroin or disguised as prescription pills. And we even have a substance called carfentanil. So fentanyl, as you know, is 50 to 100 times more powerful than morphine. Carfentanil, which is actually an opioid developed for elephants, for large animal veterinary use, is 100 times more powerful than fentanyl. So if you do the math, it is up to 10,000 times more powerful than morphine and has been seen in Pennsylvania, and obviously extremely lethal substance. This article from Frank and Pollock talks about the fentanyl threat to public health in the New England Journal of Medicine in 2017, that fentanyl's low production costs and high death toll pose a distinctive challenge to public health. So what I'd like to do now is to talk about the Commonwealth's response. The administration is dedicated to addressing this in partnership with the legislature, in partnership with our communities and our counties, as well as with other states and the federal government. And so our first category is prevention. And we do have prevention activities through the Department of Drug and Alcohol Programs and the Department of Education through schools. I'm going to emphasize the prevention efforts with medical professionals. And the term that I like to use for this is opioid stewardship. Opioid stewardship. And the parallel, of course, is to antibiotic stewardship. Antibiotics, as we all know, are extremely necessary medicines in our medical toolbox, but because of the overprescription of antibiotics, as well as overuse and certainly in agriculture, we have significant problems with microbial resistance. And so we all have to learn to use antibiotics more carefully and more judiciously. In parallel is opioid stewardship, a word coined, I believe, at least in Pennsylvania, by Penn State Hershey Medical Center, that opioids are essential medicines for severe acute and chronic pain. And if you're at a local emergency department with a fractured leg, or you have a child who had an operation this morning, they need an opioid. And if you have patients with chronic pain, such as cancer pain and end-of-life care, they need an opioid. But because of the overprescription of opioids that I've been referring to, we all have to learn to use opioids more carefully and judiciously. Thus the term opioid stewardship. So we worked with actually the deans for education of all the medical schools of the state, including all the allopathic and osteopathic medical schools, for education of medical students. And we developed a set of core competencies for education on opioids and addiction, which I was pleased to co-author an article with Dr. Michael Ashburn, who runs the pain clinic at Penn. And again, this task force of all the deans. And so these would be their core competencies, that all medical student graduates should understand the core aspects of addiction, how to screen patients for substance use disorder, how to refer patients for evaluation and treatment, assessment of patients for pain, proper use of multimodal treatment options when treating acute pain, not only opioids, proper use of opioids for treating acute pain and chronic non-cancer pain, risk assessment for SUD for those patients, and how to initiate treatment, monitor treatment, and how to discontinue treatment for chronic non-cancer pain. In addition, we developed continuing education modules in collaboration with the Pennsylvania Medical Society, as well as other professional societies, and this is for physicians and their license, but also for other prescribers and dispensers. So there is a new state mandate for 2 hours for a relicense and 4 hours for a new license on opioids for our license, which is coming due in December. And these 6 modules are available on the PA Med Society website for free, whether you're a member of PA Med or not. And they meet the requirement for our license. They also meet the requirement, they count towards your requirement for risk management and quality care, for quality assurance that is necessary for our license. So this talks about our guidelines, naloxone, referral to treatment, our prescription drug monitoring program, and alternatives to opioid therapy. There are other modules, I'm sure through AAP and others, about opioids, which would count towards this requirement. We also have prescribing guidelines. We have 10 opioid prescribing guidelines, including a new one from 2017 for pediatrics and adolescent patients. Those are available on the Pennsylvania, on the Department of Health's website, where it's available on the governor's new dashboard for opioids, and can easily be accessible. And this was done through our opioid prescribing task force, and a group of pediatricians from throughout the state who, with 1,000 phone calls, helped us develop this guideline. Again, just done last year. These have all these guidelines have been taken to the respective professional boards, such as the Board of Medicine, for their consideration and their affirmation and acceptance. It has been shown that voluntary guidelines can be helpful in decreasing opioid prescriptions. This is an article from Temple in 2015, that voluntary opioid prescribing guidelines decreased significantly the rate at which opioids were prescribed in the acute care setting. So we have a lot of confidence in our guidelines, and we want to do even more to get the word out, and that's why I mention it at this webinar. We also have, of course, our prescription drug monitoring program, which I'm sure you're familiar with now. This is a critical online tool to help clinicians in identifying patients who might be struggling with the disease of addiction and to connect them with treatment services. So as you know, before any opioid prescription or benzodiazepine prescription, you have to check the PDMP to see if the patient has been potentially doctor shopping and getting multiple prescriptions, or their family. And that's true now for every prescription for opioids or benzodiazepines, and is true for other controlled substances with any new prescription or any change in dosage. The PDMP is really a fantastic tool in this fight. We have registered almost 100,000 users since it opened in August of 2016. We have over 1 million patient searches per month. We have seen a 12.6 drop, and now a 13.4% drop in the number of opioids dispensed in the second year of PDMP implementation. We have some new initiatives. We have an interstate data sharing with the states that in all of our contiguous states. We have one-way sharing in Maryland because of their law, but I think that that's even changing as we speak. We have virtually eliminated doctor shopping since August of 2016. So the number of patients who are going to multiple prescribers has gone down, almost 90 to 100%. We are working to integrate the system with electronic health records and pharmacy management systems. And in a number of health systems, it is now perfectly integrated with their EHR. and we're working health system through health system, hospital by hospital, and then eventually physician's office by physician's office. We also have an interactive data report to look which is available on the PDMP website to look at trends at the state and county level. And we're hoping this summer actually to be able to send out to every physician kind of a report card of where you stand in terms of controlled substance prescribing. I know it is a heavy lift that we require the PDMP to be used with all opioids and benzodiazepine prescriptions, but the data shows that that is where you start to decrease opioid prescriptions and overdose death rates, that it has to be mandatory or otherwise it's not used effectively. So I know it's challenging, although as integration with EHRs happens, I think that it'll be easier and easier. Of course, it doesn't have to be you personally as the physician. It could be someone in your office that checks the PDMP for you and then documents. I wanted to highlight the opioid data dashboard. This is available on the governor's open platform database and has really very interesting data county by county as well as statewide about the opioid epidemic. We have these prevention activities outlined, including all of the different things that I've been telling you about. We have data about naloxone distribution, which I'll talk about in a minute, and then data about treatment and where treatment is available. We have a very robust prescription take-back program. In addition to the quarterly take-back days that Health and Human Services runs for the federal government, we have take-back boxes throughout the state. We actually have 711 prescription take-back boxes. If you go to that website or the data dashboard, you'll see where they are. It's a little hard to see on this map, but you can see that we pretty much cover the state in take-back boxes. Not only, you know, when opioids are overprescribed, not only can the patient for whom it's been prescribed suffer from potentially from dependency and addiction, but actually if they don't take it, then it can be diverted in 1,000 ways, including children getting into it and teenagers using it or distributing it to their friends. So we really want to get opioids out of the medicine cabinets and to destroy them, and we have 711 take-back boxes throughout Pennsylvania. I believe that's the most of any state in the country. Excuse me? Okay, so the next, I'm continuing, I'm sorry. The next category is rescue, and that includes naloxone. Naloxone, as you know, is an antidote to an opioid overdose. It is safe and effective. It does not make anyone high. You can't become addicted to it. And so in 2015, I signed 2 standing order prescriptions for naloxone. The first was for first responders, and then a standing order for the public. We're talking about primarily the naloxone nasal spray. It does also includes the FDA approved one on the left, the pre-filled tube with this little atomization device in the middle, and then the auto injector on the right. The auto injector, some commercial insurance companies will pay for. Medicaid pays for the nasal spray, and the nasal spray is much cheaper. It does not, the standing order does not include intramuscular naloxone drawn up and administered with a syringe and needle. We have actually new data just off the press is that we have 7,200 reversals with the number with naloxone provided by police in Pennsylvania. And since 2000 and at the beginning of 2015, police have saved over 7,200 individuals with naloxone. Now there is some multiple uses, so it's really best total reversals. We don't actually know how many individuals because some people have to have it multiple times, but thousands and thousands of people have had their lives saved with naloxone through the standing order for first responders. There is training for individuals to get naloxone training if they obtain it through the standing order. So I just want to go back for a second. So the standing order for the general public means that anyone can go to any pharmacy in Pennsylvania and obtain naloxone based upon my prescription as Physician General at that time and now Secretary of Health. And the purpose is to get naloxone into the hands of the public, as recommended recently by the Surgeon General of the United States, Dr. Adams. And so if you have family members in which one of their loved ones has an opioid dependency and potential addiction, they can obtain the intranasal naloxone to use at home based upon my standing order. Medicaid will cover the naloxone. CHIP covers naloxone. Really, I believe all the commercial insurance companies cover naloxone to be able to be able to obtain it for a family who has a loved one who suffers from the disease of addiction. We also have worked with schools with the company to have access to naloxone. Now, I know that naloxone is absolutely necessary to save someone's life. It's impossible to get into treatment if you're dead. However, naloxone, although necessary, is not sufficient. We have to get people into substance use disorder treatment, opioid use disorder treatment. And it can be extremely challenging for families who've had their loved one who've been resuscitated a number of times, or for the first responders and the emergency department, and we realize that. And so we want to work even harder to get people suffering from the disease of addiction with opioids into treatment. But they have to be alive to access that, and thus the emphasis on naloxone. The governor has obtained $5 million in last year's budget, the 17-18 budget, to purchase naloxone for first responders. So we can give first responders through the counties naloxone free. That includes police, EMS, and first responders can include librarians. So lots of opportunities to have naloxone in the community to be able to reverse overdoses. But we have to get people into treatment. So with the Department of Drug and Alcohol Programs and the Department of Health and the Pennsylvania College of Emergency Physicians, we developed this warm handoff clinical pathway for emergency departments to get people into treatment. And we just finished 6 regional summits throughout Pennsylvania where we brought all the stakeholders together to get people into treatment. And so what this protocol involves is that if someone is in the emergency department after an overdose, the emergency department will call the SCA, which is the single county authority, the drug and alcohol authority for each county, who will actually send someone, often a peer recovery specialist, to the emergency department to talk with that person and if their friends and family, if they're available, to work to get them into treatment. And so we very much need to get people who have overdosed or anyone suffering from the disease of addiction into treatment. We also have a drug and alcohol treatment services hotline that you can see here, 1-800-662-4357, or in other words, 1-800-662-HELP. This is staffed 24/7, and we have thousands of phone calls per month of people calling this hotline, and they will work to get somebody into treatment, or a family can call. And so when people say they don't know how to access treatment, really this hotline, the people on the hotline will work to get people into treatment who need help. Now, we've also have to significantly expand access to treatment for opioid use disorder. Now, there are lots of different treatment possibilities, And for patients suffering from opioid use disorder, for indicated patients and selected patients, we of course want to individualize the treatment to the patient. Then inpatient rehab and abstinence-based treatment might be indicated. But studies from SAMHSA and NIDA indicate that really the evidence-based treatment for many patients, if not most patients, with opioid use disorder is medication-assisted treatment. And that includes medications of methadone, buprenorphine, and there are specific buprenorphine compounds, and long-acting naltrexone, and there are brand names that are commonly associated with those. And we have to make sure that we do that in an evidence-based quality way. There's no magic medicine, but the medicine accompanied by counseling and therapy, as well as with case management and wraparound services, really offers many patients their best chance for recovery. So for patients with Medicaid, the Department of Human Services has opened 45 centers of excellence throughout the state. And you can see there was round 1 and round 2 for treatment of patients with Medicaid with medication-assisted treatment. Now, we still have to expand access to treatment. Only 1 in 10 individuals have access to treatment, and we're trying to expand access to evidence-based outpatient MAT for patients with opioid use disorder. And to do that, we need to get more patients to get their buprenorphine waiver, the 8-hour training from the DEA. And there is evidence and data, a growing database about use of medication-assisted treatment with adolescents. That a person under 18, if you have some documented unsuccessful attempts at detox and rehab, that they are suggesting that MAT might be indicated. There is evidence of medication-assisted treatment in specialty treatment for opioid use disorder, but unfortunately, very few adolescents have access to quality MAT. Can you hear me now?
Perfect. We can hear
Great.
you again.
All right, let's go on. Next slide. All right, so we obtained funding from the 21st Century Cures Grant, and we obtained funding for 17-18 of $26.5 million, and for 18-19 another $26.5 million. We're waiting for the vehicle for the next set of funds. And one of the things that we're funding, in addition to really all the efforts that we've been discussing, is a program called PACMAT. Now, that's not Pac-Man, that's PACMAT, which stands for Pennsylvania Coordinated Medication-Assisted Treatment. And we have had $4 million grants for this program to Penn State, Wellspan, Geisinger, and Allegheny, and a separate $5.7 million grant through University of Pittsburgh Medical Center for PACMAT. So there are 5 PACMAT programs now. There'll be 3 more coming with new funding. And PACMAT is a hub and spoke model. And so let's use, I just spoke with some people at Penn State Hershey, so we'll talk with them. So at the hub is their addiction specialist team. And for Penn State Hershey, her name is Dr. Sarah Kawasaki. The one for UPMC is Dr. Antoine Duahay. So the addiction specialists at the center and their team, and then the hub would network with the primary care physicians throughout their network, which is the spokes. It's a hub and spoke model. The primary care physicians, and I actually just spoke with some of the adolescent medicine physicians at Penn State Hershey about being buprenorphine providers, would provide direct care, including, say, buprenorphine, and all the patients would receive therapy, and they would coordinate with the single county authorities, the drug and alcohol authorities of each county. The hub would do the policies and procedures, they would consult, they would provide clinical education, technical support, case management, quality measurement, outcome measurement, referral, coordinate care, and do direct treatment when necessary. So the hub would be coordinating all the care, and the spokes would be the ones writing the prescription and helping and coordinating things with their hub in these health systems. The financing, the primary care doctors would be fee-for-service, but the hub would be working with insurance to get a risk-adjusted capitated rate, a global rate to support the hub. And the savings would be in better patient outcomes, reductions in overdoses, and reductions in inpatient rehab. You can see on this slide what PACMAT would look like. The addiction medicine specialist team at the center, at the hub, coordinating with primary care physicians, family physicians, could be pediatricians, adolescent medicine specialists, drug and alcohol counseling, etc. So this is loosely based upon hub and spokes models in Vermont and in Rhode Island. Of course, we have a bigger, more diverse state, larger cities, even more expansive rural areas, and so it's a little bit more ambitious. Thus, we're going to have at the end at least 8 PACMAT programs that will be working on this. Now, I wanted to spend a minute looking at our new opioid disaster emergency. So the governor declared a disaster declaration for the opioid crisis. One of the reasons why he declared it in this way is actually we found that in Pennsylvania, there is no way for the Secretary of Health, me, to declare a public health emergency. So we're actually working with the legislature to see if we can initiate that type of legislation. But right now, we're working on the disaster declaration. It lasts 90 days, and we're on our second declaration. This established an opioid operations command center. That's where I was this morning. We've had a number of different specific initiatives. As part of the first disaster declaration, we expanded access to naloxone. Actually, EMS can leave behind naloxone if patients refuse to go to treatment. We've expanded access to the PDMP to other Commonwealth agencies. We added overdoses and neonatal abstinence syndrome as reportable conditions. We've waived birth certificate fees for individuals with OUD to be able to get them into treatment. We had some emergency purchases and some waiving of licensure requirements. And I rescheduled those synthetic fentanyls. This is not the medicine fentanyl, but synthetic fentanyls to align with the DEA schedule. So in the second iteration of the disaster declaration, we're working on other initiatives with every agency. So this is a unique partnership with public health, human services, with public safety and PEMA, as well as with law enforcement. So we have the Pennsylvania State Police there, we have the Department of Corrections, the Commission for Crime and Delinquency, we've added state, we've added recently the Department of Education, Military and Veterans Affairs, etc. So, basically almost the entire structure of the administration is participating in this effort. We were out in Washington County and we did a command center in the community with the governor 2 weeks ago. We're going to do those throughout the state to engage regional stakeholders in our discussion. We have brought some stakeholders to PEMA. And we have the data dashboard that I indicated earlier. We have a new contract with the University of Pittsburgh School of Public Health for Data Dashboard 2.0 to be able to use data to inform our policy. So, I guess I would say in conclusion that, this is the public health crisis of our time. We have over 5,000 individuals that are dying each year of overdoses. In the United States, there are over 60,000 individuals dying each year of overdoses. Can you imagine if that was an infection? I mean, think about the Ebola crisis, which was a potential public health crisis, but about 4 to 6 people died in the United States of Ebola. We have 60,000 people each year now dying of overdoses. And so, this is a public health emergency, and we all need to work together to address this. So the medical community, pediatricians included, all of our other physicians, organized medicine such as the AAP and others, with other public health and medical professionals, with the community, with government, with our communities to address this. Now, I'm a positive and optimistic person, and I think that we're making progress in 5 years and doing better in 10 years. But we're in it for the long haul to be able to address this. It's been 20, 30 years in the making, and there's no quick fix. But I think we'll get there with your help. Thank you. And so now I'm free for questions. I'll turn this over to Dr. Renee Turchi.
Thank you, Dr. Levine, for that excellent webinar on the opioid epidemic in Pennsylvania. That was fantastic. I would like Iris Colon to give us some instructions for the Q&A portion. Thank you, Iris. So our first question, Dr. Levine, is with children being able to accept or deny help at age 14, are we as a Commonwealth looking for ways to be able to better help children who are still too young to understand what their needs really are?
Well, so a couple of things. One is that for prevention activities, there are robust activities that we're doing with the Pennsylvania Department of Education in terms of primary prevention of drug use and addiction in our schools. In addition, even though the age of consent is at 14, if you have someone who's 14, 15, 16, or 17, and you feel that they have a substance use disorder, you can, it's always a question in adolescent medicine is whether you contact the parents. But if you think someone has a clear addiction to something like opioids, that might be an indication to break confidentiality, tell their parents, and get that person into treatment. And the parents can insist upon treatment in Pennsylvania for under 18, even if the patient doesn't agree. Question is sometimes how effective that will be, but I think that if you have someone with clear opioid addiction that is at risk of overdosing, that, as an adolescent medicine specialist, that might be a time that I would break confidentiality.
That makes sense. Thank you for that.
Another thing would be to make sure the family has naloxone at home in case of an overdose.
Our second question, Dr. Levine, what are we as a Commonwealth of Pennsylvania doing to understand the scope of the problem related to its effect on pregnant women and newborns? And do we have resources and social support for families?
Absolutely. Several different things. First, we have prescribing guidelines for OBGYN, as well as a specific prescribing guideline for opioid use disorder in pregnant patients. This was done with obstetricians throughout the state, including some really fantastic programs as evidenced by McGee Women's Hospital at UPMC, which has a landmark program which has been published. And so I'd recommend that you look at those guidelines. In fact, a significant portion of the 21st Century Cures funding for 18-19 is going toward exactly that, is expanding access to treatment for opioid use disorder in pregnant patients, because studies show that if those patients are treated in an evidence-based system usually with medication-assisted treatment such as methadone or buprenorphine, that the babies will have a much lower incidence of severe neonatal abstinence syndrome and do much better. In addition, we have made neonatal abstinence syndrome a reportable condition. You can go to the data dashboard now and see where the cases of neonatal abstinence syndrome are. So we're trying to get a better handle on that. So I don't remember the exact percentage of hospitals, but I believe it's at least 75% of hospitals are reporting now, and we're hoping to make that 100%, as we've made it a mandatory reportable condition. And we would love to network and work with the Pennsylvania American Academy of Pediatrics to work on treatment of that. We're also working with a multi-agency work group on how best to treat the family in those cases and how best to have follow-up for the mother and the baby, and to make sure that mom stays in treatment and that the baby is cared for, such as nurse-family partnerships, etc.
Great. And I'm sure as a chapter, we'd love to be working with you on that, Dr. Levine.
Great.
Our next question, is there any way the system at PDMP can monitor a provider's number of opioid prescriptions in a given time frame?
So the Pennsylvania Prescription Drug Monitoring Program does monitor each physician's prescriptions for controlled substances, so over a period of time. So we do have that data. And the primary use of the PDMP is for you, the physicians, to use that in terms of your prescribing, is that you check the PDMP whenever you're going to write a opioid or benzodiazepine prescription or with any controlled substance, to make sure that the patient hasn't been doctor shopping. If the patient has been doctor shopping, or the family, etc., or maybe misusing those prescriptions, you don't want to abandon that patient, because then they're at risk of going to heroin. You want to make sure that you refer that patient to treatment, and you can find all of that. You can call the hotline, or you can find that data about where there's treatment on our data dashboard. We will be sending out a patient report card to each physician this summer. I don't know the exact timetable. And we do network with the Department of State and the Attorney General's office for the few bad apples that might be running illegal pill mills. And there's a complex algorithm behind how that looks at. I mean, again, I'm a positive, optimistic person. I think that if a physician is over-prescribing, most likely that physician needs more help in terms of how to do this better, maybe has inherited a lot of patients. And so there's a great program through PA Med about in order to the lifeguard program and to educate physicians about how to treat pain better. It's like a 2 or 3 day course. But of course there are some bad apples among us, and the PDMP will be able to find them too.
And Dr. Levine, there's also some, I think we can even maybe get this out to our network or in the chapter. I think you had a work group, an opioid prescribing work group for professionals that the chapter was a part of, and I think there's some publications in pediatrics. So maybe that's something we can actually house on our website at the chapter, in addition to the great point you made about the webinar. Maybe we can even get some of the pediatric-specific prescribing guidelines out for our membership.
Absolutely. Just we'll be glad to work with you to get any of the pediatric specific guidelines, or maybe even the OBGYN guidelines, or the guidelines for opioid addicted pregnant women and stuff, for high risk pregnancies, etc., out to you. So that would be absolutely great.
Great. We will work on that. That sounds great. We had just a couple more questions, Dr. Levine. I don't know if anybody on the phone has one. But this question is, how is the state partnering with DHS to ensure that foster parents are prepared for NAS infants? I know I've had parents, I think there are some courses, but I wonder if you could speak to that.
Well, again, the Department of Health and Department of Human Services work hand in hand. As well as the Department of Drug and Alcohol Program. So we are absolutely on the same page. And we do have a specific work group about actually all substance addicted newborns. I don't know specifics about how that information gets to the foster system, but I'll check on that.
Great. We can get that back to our group.
Sure.
We also have a question here. What services or programs are available for pediatricians to refer when parents of infants and young children appear to be struggling with addiction? I think you, in addition, aside from early intervention or child link, I think you addressed some of this in the earlier question, but was there anything additional, I think in terms of the website, was there anything additional you wanted to comment on that question?
So I guess, are we talking about a newborn that might be having neonatal abstinence syndrome, or a older child or adolescent who might be suffering from substance use disorder themselves.
I think it was more the parents. It sounds like they want to know about the parents of infants and young children who appear to be struggling.
Right, right. So, you know, it depends on their insurance, but there are, I mean, one thing is you can always call the hotline. So, you know, or you can always either refer the patient to the hotline or you can call the hotline themselves. There are, and that those patients would be very, very well treated by the Centers of Excellence if they have Medicaid, or by one of the PACMAT programs. And, you know, then the question becomes whether you call Childline or not. And, you know, I think that if you're concerned about the safety of the child, then a Childline call would be appropriate as well. Let me give you the number again of the helpline. The general helpline is 1-800-662-4357.
Great, and we can put that out to our membership and on our website as well. I know we only have about 5 minutes left. Is there anyone on the phone that has any questions for Dr. Levine? Dr. Levine, it looks like we also had some folks who responded to some of your discussion, very appreciative of your answers and are interested in some of the opioid guidelines. So we maybe will work on pulling some stuff together for our website, but might email you to see if there's anything that we've missed, if that's okay.
That would be great.
Everything that we're aware.
That'd be great. Thank you.
So, great. Thank you. We really appreciate your time today, Dr. Levine. We know how busy you are, and this is just such a timely and essential topic for us in primary care. So we appreciate that that you were willing to speak with us today. So we want to thank you for this excellent presentation, and we also want to thank the Pennsylvania Department of Health for the funding that makes this webinar possible. And don't forget, for those of you that, you know, please complete your evaluation of the webinar. And at this time, I would like to say this concludes our webinar, and thank you, Dr. Levine.
Thank you very much. It was a pleasure. Bye now.